Thank you all for joining, and I will now introduce today's presenter. Dr. Tyler Robin is an Associate Professor of Radiation Oncology and Director of Genitourinary Radiation Oncology at the University of Colorado School of Medicine. He graduated from Colorado College cum laude with a distinction in biology and then completed the combined MD-PhD medical scientist training program at the University of Colorado, where he studied strategies to improve the effectiveness of cancer therapies with the support from the National Cancer Institute. He then completed the radiation oncology residency training program at the University of Colorado, where he served as chief resident. He continues to enjoy mentoring medical students and resident physicians. He has an active clinical research program and has published over 60 research articles and textbook chapters. He is a member of the NCCN Prostate Cancer Panel and NRG Genitourinary Cancers Committee. Locally, he chairs the UC Health Oncology Service Line Genitourinary Cancers Joint Operating Committee. Outside of work, he enjoys spending time with his family, skiing, biking, hiking, and movie nights. Thank you, Dr. Robin, for being here with us this afternoon. I will stop sharing my screen and turn things over to you.
Great. Thank you for having me. I appreciate the opportunity. Clicking through things. Hold on. There we go. Do I have the right thing up?
Yes, you do.
Looks like it. Beautiful. Uh, Perfect. So I was asked to present on this clinical trial that we ran through the IIT program at the Cancer Center. And let's see, I have no disclosures relevant to the content of this presentation. I do want to upfront just acknowledge my collaborators. This was a multidisciplinary team of folks from radiation oncology, which is my home department, as well as gynecologic oncology, Dr. Diamond from medical oncology in phase 1, as well as statistics support. And I'll take a moment just also to remember a colleague and friend who collaborated on this project, who has since passed. I want to thank all the patients, of course, that participate in this clinical trial as well. All right, moving on to the meat of this. So walking through this, the idea was to sort of take the group through what started as an idea and how it matured into a IIT and ultimately what we found and walk through some of the pertinent results and findings. And then, of course, I'm happy to take as many questions as you guys all have at the end. So this is a kind of a case-based thing to start a little bit, but this is a 51-year-old woman with recurrent high-grade ovarian cancer. She's had 2 prior extensive debulking surgeries, and she's had multiple lines of prior chemotherapy. On her most recent restaging scans, this is a PET scan image. That's a cross section on the left, and then that's sort of the whole body projection on the right. And that sort of bright orange area on the left, or the dark black area on the right, highlighted by the orange arrows, that's the area of cancer recurrence that she's now facing. And I think the image on the right shows it the best, and that is that everything else you see on that scan that's a little bit dark is completely normal. So below the arrow there, that's just the bladder, and that's the bladder normally excreting the tracer. Everything else is completely normal. And so this is really an isolated, small area of recurrent cancer. Now, there are 2 things we could typically do in this scenario, and the third is sort of the idea behind the trial that we ran. So the first is you could give more chemotherapy, right? And the potential downside of that is you're giving whole body therapy that has whole body side effects for a single site of cancer that you can identify on a scan. The second is more surgery, right? You could, without giving whole body therapy, go in and do another operation to try and find that lymph node and resect it. Downside of that is this patient's already been operated on twice before. And sometimes patients don't want to undergo another surgery or do something invasive. Sometimes that can be a challenging thing for the surgeons to do, to go back in a 3rd or 4th time in these patients. So the last is, could we just get rid of this spot or ablate this spot with a technology called SBRT, or stereotactic body radiation therapy? And the other term for that is SABR, or stereotactic ablative body radiotherapy. So I think it's important to first try and give this group a sense of what SBRT is and how it differs from sort of some classical or uh, kind of what would be considered antiquated radiation treatment in this specific scenario. So on the left, I've highlighted in these red boxes what sort of your classic large field radiation may look like. So this would be a low dose each day over many days, targeting a big area. Um, and you can do that in this situation, but you tend to have sort of more side effects than people bargain for, right? Diarrhea, sometimes some nausea, depending on how high you have to treat. It can impact the bone marrow and the cell counts, potentially inhibiting the ability to receive further chemotherapy. And so that's something you would want to do cautiously. And then because we're using big areas, we can't go to as high of doses. So the doses also may not be effective against what we're treating. SBRT, on the other hand, is an advanced radiation technique. It's defined by large doses of radiation delivered in few fractions, resulting in a high biologic effective dose with high conformality and rapid dose fall off. So that's kind of demonstrated by the cartoon red circles on the right there. And we really have the ability with modern radiation treatment to pick out a small spot and treat it in a very focal, high dose ablative way. And so that's really the premise behind this study is, can we use this technique in this patient population? Is it safe and is it helpful? So there are several established uses for SBRT. We can use this technique to treat primary lung cancer, liver and lung metastases, commonly used for spine metastases and non-spine bone metastases. It's used in localized prostate cancer. And the list actually probably goes on and on. But the question here was specific to whether this could be used in recurrent ovarian cancer where it has come back in the abdomen and pelvis, specifically adjacent to bowel, and in a patient population that's had extensive prior lines of systemic therapy and extensive prior surgeries. So these patients may be sort of more prone to complications from this treatment than, for example, somebody that has a lung metastasis in an untreated lung in good health. So here are some examples of what actual SBRT dose distributions look like in actual patients. These were actually patients treated on this trial, but just to give you a sense of what we're asking. So can we treat these small areas? And this is called a dose wash dose distribution here. So the red is the highest radiation dose, and the blue in some of these is more like a lower intermediate dose level. And so you can see is that we're able to treat these very small areas in a very focused way. But these sites are adjacent to bowel in patients that have often had prior, again, surgeries that may make their bowel more fixed and prone to injury, or types of systemic therapies that could potentially make them more prone to bowel injury. And so it is a little bit of a different question than some of the more common uses for SBRT in the literature. So that was the idea. Can we use this technique as a non-invasive way to ablate limited sites of recurrence for patients with ovarian cancer to allow them to avoid either additional whole body therapy with whole body side effects or additional surgeries and the potential risks that come with that? So we took this concept to, at the time, the IIT incubator, and we iterated on this concept and ultimately came up with this schema. So we decided to run this as a 3+3 dose escalation study. Patients were eligible if they had primary ovarian cancer, as well as primary cancers of the fallopian tube or primary peritoneal cancer. Those as a group are all considered sort of the family of epithelial ovarian cancers, so similar histologies. We wanted to test this concept in adult patients with good performance status. And then what we wanted to do this in patients that had limited sites of disease. So we decided on 3 or less sites of active disease in total. And at least one of those sites had to be amenable for SBRT and pertinent to the question that we're asking. So less than 5 centimeters, because we didn't want to, first time around, be treating really big areas of cancer deposits with this technique. That's not like the basis for it is not in large tumor deposits. It's in tumor deposits predominantly under 5 centimeters or so. Um, and we wanted the sites to be in the abdomen or pelvis because that's where we were worried about additional toxicity that we may not see when treating, again, lung metastases or liver metastases where there's a more established role of this technique. And so, for example, this is a little complicated, but a patient could have two lung metastases and one lymph node in the abdomen, and they would be eligible for this study. You would treat the lung metastases off study, but you would treat the lymph node metastasis in the abdomen on study. And so a little bit nuanced as far as the inclusion criteria, but a total number of disease sites that make them limited or oligometastatic, where we don't believe that they need systemic therapy per se, and at least one of those sites in an area that we that's really pertinent to the trial question. So sorry, I didn't finish the schema here. So then the schema, it's a dose escalation study. We started with 24 gray and 3 fractions as dose level 1, went up to 27 gray and 3 fractions for dose level 2, and 30 gray and 3 fractions for dose level 3. There was some retrospective data looking at 24 and gray and 3 fractions in this clinical scenario, which is why we use that as our starting dose. Patients were monitored for 12 weeks for the dose limiting toxicity monitoring period before we escalated to the next dose. And then, the primary endpoint was maximum tolerated dose of SBRT on this phase 1 study. But it was important for us as a study team to also look at some oncologic outcomes. So we, at 12 months, looked at local control, progression-free survival, overall survival, freedom from systemic therapy, which we'll go into when I present the results. But for some of these patients, right, the goal is do something to avoid another line of chemotherapy. And so we wanted to find out, when we did that, how long could you go before you needed to actually start chemotherapy? We looked at global toxicity as well as some quality of life endpoints. And then we integrated some exploratory studies. And so we looked at perfusion imaging metrics in patients that underwent SBRT to these sites of abdominal and pelvic tumor recurrence. And I'll walk you through those results as well. So that's the concept. This was opened in, I think, May or June of 2017. The blue is the projected accrual and the green is the actual accrual. Like almost every study, there's a little bit of a ramp-up period between opening and actually starting to put patients on. But this really met projected accrual pretty quickly. And in 2019, we had fully accrued the initial dose escalation cohort. There were no dose-limiting toxicities in that cohort, and so we decided to open an expansion cohort to increase the kind of the power to answer some of those secondary endpoint questions. And so in 2019, we opened the expansion cohort. The trial continued to accrue at about the same pace as it was accruing in the initial phase, and we completed accrual in 2020. So time to analyze the data. Our paper was published in 2025. I just showed you that we completed accrual in 2020. There's about a 12-month follow-up period, so there was a long delay before actually getting this data out. I'm going to blame COVID, like we blame COVID for everything, but I think that's real. We were just starting to want to analyze this data when everybody was trying to reinvent how they work and where they work and who they're working with. And so that caused a little bit of a delay. And then this paper, unfortunately, was under review at one journal for an exceedingly long period of time. But ultimately, what started as an idea and a concept through the IIT program resulted in a publication of our phase 1 study. And I'll walk you through what we found. So we ended up enrolling 15 patients. If you remember, you could treat multiple sites in a single patient. So up to, if you had 3 sites in the abdomen or pelvis, you could treat all 3 of those sites on study. So we ended up treating 23 targets on study in 15 patients. The median age was 58. These patients all had an excellent performance status, either ECOG of 0 or 1. They were predominantly what was classified as recurrent ovarian cancers, but also some primary fallopian tube and primary peritoneal cancers. These were mostly serous ovarian cancer, although one patient did enroll with uh, carcinosarcoma, which was eligible per study. This is the stage at initial diagnosis, so it's kind of split throughout. So some of these patients had early disease when they were initially diagnosed and recurred with metastatic disease. Some had metastatic disease at diagnosis. Ovarian cancer can be driven by BRCA mutations, so we did look at that in our patients, especially as that can sometimes dictate additional lines of therapy. The majority of the patients in this study did not have BRCA mutations. And something that's important in ovarian cancer outcomes is whether or not your initial surgery is what's classified as an optimal cytoreduction surgery. And so we just looked at who had an optimal cytoreduction up front and who had a suboptimal cytoreduction. The majority of patients did have a suboptimal cytoreduction. The median time to first recurrence in this cohort is 24 months. Most patients did not actually have second cytoreductive surgery, so different than the initial case that I walked through, but about a third of the patients did actually have 2 prior surgeries before this recurrence. The median prior lines of systemic therapy was 2, so that is very similar to sort of the case vignette that we went over. Ovarian cancer that's receiving systemic therapy gets classified as platinum sensitive or platinum resistant. Most of these patients actually were still sensitive to platinum agents at the time of SBRT on trial. And then the overall median time from diagnosis to SBRT was 33 months. So that's the patient cohort. Again, you could have multiple sites treated on trial in a single patient, although about half of the patients we treated a single site of metastatic disease or a single lymph node, and about half the patients it was 2 or 3 sites. The areas that we ended up targeting, so about a third were periaortic lymph nodes, about a third were pelvic lymph nodes, and then about a third were not nodal deposits, were not lymph nodes or something else. So some of those were peritoneal deposits, and we classified those, even though it may have been a small peritoneal lymph node, it didn't classify as a pelvic or periaortic lymph node. This next table on the right is going to be really busy for anybody outside of radiation oncology, but I think it's important, and so I'm going to walk you through what these things are and what it means. So in radiation therapy, the GTV is the gross tumor volume. So that's basically the lymph node or tumor deposit that you see on the scan. The PTV is a margin around that that's accounts for any daily setup uncertainty and very, very small levels of uncertainty in the targeting. Again, that ends up being very small, so margins of maybe 3 millimeters around the target for something like this, but it is a margin of normal tissue around the target. And then the duodenum, small bowel, and large bowel are the primary, what we call organs at risk, or OARs, that are relevant in this situation. And so we looked at the size of the GTV. So that's basically the size of the tumors that we were treating. These were relatively small. So the median tumor size on this study was 6.7 cc's, although the largest was 46 cc's. And then we looked at the PTVD 98%. So that basically looks at the dose that 98% of the PTV received. And the reason this is important is we had 3 dose levels on this study, right? 24, 27, and 30 gray. And then what's interesting is, we were limiting. So if you had the PTV overlapping, say, small bowel, right, you could still treat that tumor, but you may undertreat a small area of the PTV. So most of the PTV gets prescription dose, but a small area could be very, very undertreated to protect the bowel. And so we wanted to look in our study cohort, how undertreated were some of these areas, or were the PTVs pretty well covered? Because I think that makes a difference for applying these results more broadly. And what we found is that the median PTV D98%, again, was 26.5, this is gray, in a trial that allowed 24, 27, and 30 gray. So the PTVs were pretty well covered. And the GTV here, which is the actual tumor, same thing. It actually saw an even higher dose, closer to 30 gray or 29 gray. So that just speaks to the fact that we were able to accomplish this from a safety standpoint without needing to excessively undertreat the areas of cancer. And when you look at, so the D0.035 cc's, that's basically a surrogate for the maximum dose to the duodenum, the small bowel, and the large bowel. And what we did was look at only cases where that's relevant, right? If you have a tumor that's 15 centimeters from the duodenum with these tiny little targets that I showed you, well, then the dose to the duodenum is going to be 0, and that's going to skew the finding. So instead, we only included cases where the normal organ at risk was adjacent to or in close proximity to the target. And for the duodenum, in about a third of the cases, the duodenum was in play. That makes sense. The duodenum sits adjacent to the periaortic lymph node regions, and it was about a third of cases that we treated periaortic lymph nodes. The median of the maximum dose to the duodenum, sort of a mouthful, but was 25.8 gray. So that gives you a sense of what was tolerated on this study. For small bowel, the majority of the cases had small bowel in proximity. So that also tells you that we didn't sort of cherry pick patients with great anatomy to enroll in this study. This is representative of a real patient population. And the median small bowel max dose was 20 gray. And then the large bowel, which can tolerate a slightly higher dose than the small bowel, same thing. The majority of patients, there was some large bowel in play. And the median of the maximum dose to the large bowel was 17 gray. So overall, to review, kind of recap the methodology to look at toxicity, the dose-limiting toxicity was defined as treatment-related grade 3 or higher adverse events. The dose-limiting toxicity monitoring period was 12 weeks after SBRT. Patients were followed for toxicity for 12 months after SBRT. And what we found was that in the 9 patients included in the initial dose escalation study, we were able to safely escalate the dose to dose level 3, which was, again, 30 gray and 3 fractions, without dose-limiting toxicity. We enrolled another, followed another 5 patients in the expansion cohort at dose level 3 without additional dose-limiting toxicity. And overall, at 12 months in the 15 patients that we followed for that period of time, there were no grade 2 or higher treatment-related adverse events. So looking at, so again, we sort of summarized the toxicity. This was a very safe treatment, and that was the initial, the primary question of the study. But we were also interested in whether or not this is helpful or not, right? And so if you remember the secondary oncologic endpoints from the protocol, we were going to look at local control, progression-free survival, overall survival, and this concept of freedom from systemic therapy. So local control was excellent, 95%. So using these doses, the vast majority of the tumors that we treated responded to this treatment. So these are adequate doses in this situation, is my conclusion from that. About half of the patients were free from progression and alive at 12 months. So that means that the other half did progress. They progressed out of field, right? If the local control is 95%. And overall survival is 100%. So 100% of patients were alive at our 12-year follow-up. And then most importantly, this freedom from systemic therapy. So a lot of patients are interested in utilizing this technique, and we as physicians are offering this now because, again, it's an opportunity if you have a single site of recurrence or 1 to 3 sites of recurrence to use a non-invasive strategy to minimize sort of lifetime exposure to systemic therapy, to buy a holiday from drug. And what we found is that in our study, 15 patients were enrolled and followed for 12 months. 10 of those patients were off systemic therapy at the time of SBRT. So we used SBRT on study to try and delay systemic therapy. That was the intent. The other 5 patients, for one reason or another, were started on systemic therapy either shortly after or right before SBRT on study, and that was allowed. But at 12 months, of the 10 patients that were off systemic therapy at the time of SBRT, 70% remained off systemic therapy at that time. So this really does show, we didn't follow these patients longer than this, but the median time to reinitiation of systemic therapy, if you use SBRT in our patient cohort on this study, was over 12 months, right? And that's a big deal for patients to get a year away from drug therapy by undergoing a 3-treatment non-invasive radiation regimen that had no grade 2 or higher side effects on study, I think is a big win for patients. We also looked at quality of life, right? This sometimes it can give us signals of what's going on beyond just either, physician or even patient reported um, toxicity or adverse events. And so our patients did actually extensive quality of life monitoring rather than go through every single quality of life questionnaire that the patients filled out. I am just highlighting the QLQ-C30 global kind of health status scale. And this is every patient on trial. But if you look at the top, at baseline, the median score is about 75 with an interquartile range of 67 to 88. And that really doesn't change at 6 weeks after SBRT, maybe a little bit lower at 3 months, but well within statistical similarity, if I can use that phrase. And same thing, 6 to 9 months. And then at 12 months, again, the median is identical to what it was at baseline. So we really did not see either a clinically meaningful, statistically significant, really any difference in quality of life in patients that underwent this. And if you remember, the majority of these patients were off systemic therapy due to this treatment and allowed to stay off systemic therapy due to this treatment, whereas the quality of life may have actually been negatively impacted had they gone on to chemotherapy instead, or another line of chemotherapy. We had an exploratory endpoint looking at perfusion imaging. And so this is just sort of a very simple sub-schema, but patients underwent dynamic contrast enhanced CT as a form of perfusion imaging before SBRT, immediately after the first fraction of SBRT, and then 6 weeks after completion of SBRT. And so we looked at tumor permeability, blood flow, and blood volume. There was a slight increase in blood flow and also probably a non-statistically significant slight increase in blood volume immediately following SBRT. But by 6 weeks, a significant decline in both blood flow and blood volume in the treated tumors. And so people have looked at perfusion imaging in ovarian cancer before in a different context. So I write in context. Yeah, in a different context. So this was patients receiving drug therapy, and they actually showed something very similar. When you had decreases in blood flow and blood volume after receiving chemotherapy or systemic therapy for ovarian cancer recurrences, that correlated with improved progression-free survival. And so the question then becomes, can we further validate the prognostic significance of perfusion metrics in the post-SBRT context, right? If it correlates with PFS in drug therapy, could it correlate with PFS in SBRT treatment or at least local control? And if it did, early perfusion changes could potentially be applied to adaptive dosing strategies with SBRT. So patients that are having a good perfusion response, maybe you need less radiation. There's a lot of different ways you could integrate this, but it was really nice to see a exploratory sort of additional study correlate well with what's out there in the literature in the same disease, but in a different context. So overall, we saw no grade 2 or higher SBRT related adverse events. Importantly, and I think this is really where this trial shines and how we can really help patients, is that in patients that received SBRT in lieu of systemic therapy, 70% remained off systemic therapy at a year. There was no measurable impact, I should say, no measurable detriment on quality of life, because I think maintaining quality of life sort of is a positive impact. And the perfusion imaging findings are novel in this context, and I think can be explored further. So with that, thank you for your attention. I'm happy to take as many questions as you have. But again, I appreciate the invitation to be here and to talk about a study.
Excellent. Thank you, Dr. Robin, for a really great presentation, particularly, in sharing the background where the study was developed from and walking us through the study methodology, the toxicity information, and study results. What particularly hit me was how you were emphasizing, the safety outcomes of the study and also, the efficacy that was proven throughout the trial. Especially when it comes to patient-centeredness, the freedom of systemic therapy. You mentioned the quality of life measures, and maintaining quality of life is not necessarily a bad thing. Um, any questions, please feel free to pop in the chat. I've had a couple pop up for me. So just starting, I guess, at the end, and I can walk back towards the front of your presentation. And I'm curious if there have been any additional studies that have or will be stemming from this IIT, or can you share, what are the future directions of this research?
Yeah, that's great. So I think in parallel to us doing this, there's been a couple of groups in different countries around the world, but predominantly an Italian group that has also pushed this concept. And so I think this study combined with some of the work that they've done has really established this as a standard option or emerging standard option for these patients. So I think this has been helpful in sort of in concert with some of the work being done around the world. Uh, you know, our patients were pretty excited to participate in this study and amenable to some additional extra testing. So we did do a fair amount of blood draws on this study as well. And so I think as we are learning more about the prognostic significance of different biomarkers in different cancers, there is an opportunity to do some additional translational work just with the existing data. Um, and then, yeah, there may be opportunities again just for next phase trials or emerging different techniques. Maybe I have no idea where I was going with that. I'm so sorry. I'll be honest with you. Yes, it's this funny thing where it's like you want to hope you've done enough to start just to implement this, right? Like you're really excited about the findings, and again, it's in collaboration or in concert with what's been seen in small studies at other centers around the world. So I think there's always opportunities to design follow-up clinical trials. And then there's also just the want to move this into clinic and out of the experimental phase.
Sure, great. Thank you so much. And
Yeah.
you mentioned, scheduling perhaps more blood tests too. So I guess this leads into my next question on, what aspects of that startup process as an IIT investigator were the most complex or challenging to figure out, and then perhaps which parts of that process went more smoothly or easily than expected.
Yeah, it's a great question. I apologize. When I first started putting this talk together, my intention was to talk mostly about process. Um, but this process started so long ago, I have lost much recollection about how it actually went. And so I decided sort of focus on more of sort of the current results and what we're currently thinking about. But um, I think the IIT process is very supportive. And so, there's good mentorship within the cancer center. I didn't explicitly highlight it, but my co-PI for the study is Dr. Christine Fisher. She was a mentor for me as we put this project together. And again, we had collaboration from the gynecologic oncology service, from Dr. Diamond. We had good stats support, and so um, it really was a enjoyable, smooth, collaborative process. But certainly, yeah, I think challenges are just, anytime you're designing a trial, everybody has a different opinion on what is or isn't important, and some of those opinions aren't even from the study team, right? That can be um, from regulatory or from other areas where you're trying to balance, um, you know, patient protection, safety, cost, and still answer the question that you want to answer. But my memories of this, even though this went through a long time ago, are all very positive, actually.
That's wonderful to hear. And you mentioned your collaborators at the beginning of the presentation, and you just mentioned them again now. I'm curious if you could speak more on what their role of the process was, whether that's gynecologic, oncology, or any of the other teams that you worked with.
Yeah, I mean, it was everything, honestly. So so concept development really was a team effort. So again, my my personal mentor, Dr. Fisher, and I designed this trial in radiation oncology, but with heavy, heavy input from the other folks that I discussed. And we iterated on this a lot together. And then ultimately, the majority of these patients were identified through the gynecologic oncology clinic. So this trial absolutely would not have been successful if it weren't for um, the support from the gynecologic oncologists. And I think they were as interested in answering this question as we were. So this was a great example, I think, of a multidisciplinary successful IIT.
Excellent. And you actually lead perfectly into my next question, which was, thinking about the recruitment efforts that were employed to the study. If there's anything that you remember from 2017 through 2020, anything in particular that was deployed for this study specifically?
So again, when I was thinking of giving a talk on process more than results, I did find some old PowerPoint presentations. So I had clearly gone to the Gynonc tumor board and given talks in a couple of different venues just to, again, increase the visibility for the study. I found those talks. So again, I think that worked well. And again, in some ways, this was just a shared vision between disciplines. So it wasn't terribly hard. I mean, these patients aren't, it's not a rare occurrence. It's also not the most common presentation of ovarian cancer. So one of the reasons this isn't sort of studied in a widespread way or took a while for people to become interested in this is that a lot of times with ovarian cancer, you recur with a more sort of widespread peritoneal disease process. And so identifying patients with limited sites of disease is really saying this patient's biology is different than what we typically see. Let's use something different here. And so that's just to highlight that this isn't the majority of patients that are seen with recurrent ovarian cancer, yet, we still accrued this trial kind of on pace as anticipated. And so, um, again, just remember this as being a positive experience.
Yeah, it's wonderful. And that it leads me to my last question. And also keeping an eye on the chat if there's any additional questions come through, or also participants can feel free to unmute as well. But going all the way back to the beginning of our presentation, from your biography, you mentioned that you enjoy mentoring medical students and residents. How do you encourage, early career clinicians or scientists to get involved in clinical research or in developing their own IITs?
Yeah, I do encourage it. It is challenging and intimidating. So I usually, when we have trainees that are interested in becoming clinical trialists, I encourage them to, think of it with faculty mentorship, right? Think of an idea that is of interest to them, but also likely achievable in the period of time that they're going to be with us, right? Like if you want to study 10-year outcomes from a, you know, good biology, favorable disease process, you'll still learn a little bit from the trial development experience, but you will be long gone by the time the trial accrues and results. And so we try and, think of questions that can be answered in as short a time as possible. And then I also, even though I think prospective research absolutely is paramount and where we should put most of our energy, I encourage those trainees to have retrospective projects on the side too. So things that can be achieved sort of in small bites while they're taking the big bite.
Wonderful. Well, thank you so much, Dr. Robin. I'm not seeing any additional questions in the chat. So, for the sake of time and giving folks a few extra minutes back in their day, just want to thank you all again for coming. A reminder that as you're exiting the meeting, and we'll stay on for a couple extra minutes in case there are any additional questions. But as you're exiting the meeting, please take a few moments to fill out the survey. And we hope to see you in March for our next Lunch and Learn from Developmental Therapeutics Co-Program Director, Leah Gore. But once again, thank you so much, Dr. Robin. It was a pleasure and really enjoyed your presentation and comments on the IIT process as a PI.
Yeah, absolutely. Again, thanks for having me. It was a different team back then, but shout out to the RadOnc research team. You guys are excellent. Thanks for coming to the talk. See a lot of familiar names on here. So yeah, happy to do it and appreciate the opportunity. So thanks for having me.